So there are several options for the treatment of iron overload. Reducing the amount of transfusion as an option to reduce the iron loading is not a reasonable option. The efficacy of transfusion in stopping sickling depends upon maintaining a high enough hemoglobin level to shut off hemoglobin S production. So backing off on transfusion is going to back off on therapeutic efficacy. There is a procedure that's called erythrocytophoresis, or exchange transfusion, that can be done as an outpatient, where you basically hook the patient up to a computerized exchange transfusion machine, and you pump out the patient's blood and you replace it with normal blood. So the net change in red cells is zero. And using these kinds of techniques, it's possible to maintain the hemoglobin S concentration at a low level without iron loading. And this really is the optimal way to do recurring transfusion for sickle patients. There are barriers to this having to do with venous access, and also the size of the patient. Is difficult to do this in children that are under 2 or 3 years of age. And it's also difficult with access and financial aspects of setting this procedure up in a special outpatient setting. But nonetheless, it's a very effective way at reducing the iron loading. Phlebotomy, or just drawing blood, is used for some diseases to reduce iron. This isn't an option in patients with sickle cell disease, because you're transfusing them, you're giving them blood in order to raise their hemoglobin and shut off their hemoglobin S production. So simply drawing blood out is going to reverse your therapeutic effect. If the patient is no longer on chronic transfusion, they're anemic, and drawing blood from them is not going to be very well tolerated. So the primary treatment of this then is the use of iron chelators. And there are 3 chelators that are available in the United States. One of them, desferoxamine, is the earliest chelator that has been available now for several decades. It is an excellent medication, except it has a very short half-life. And so it has to be given by continuous infusion. If you just inject a bolus of desferol over a few minutes, the half-life is 30 minutes, and so half of that drug will be excreted in 30 minutes, and it will not be bound to iron, so you will remove very little of any iron. The standard way to do it is to put a needle under the skin on the abdomen or the leg and infuse it over 10 hours at night while the patient is sleeping every day. It's very important with any chelator that they have chelator present all the time, because whenever chelator is not present, the toxic free iron levels go up in the blood. The moment that chelator is circulating, the first thing it does is it binds the toxic form of iron and decreases the toxicity. The second job of the chelator is to remove the excess iron and excrete it in the feces or in the urine. Deferocerox, or Exjade, is an oral iron chelator. It has a half-life of 14 hours approximately. It can be taken once a day, and it is an effective chelator, and obviously much easier to use. The newer forms of deferocerox likely have fewer gastrointestinal side effects, but these forms have only been available for a few months, and we don't really know how that story is going to unfold. The third chelator is deferoprone, or Feraprox. This medication is given 3 times a day, and at 100 milligrams per kilogram, it's effective at removing iron. It also, different than the other medications, is the most effective drug at protecting from cardiac iron damage. And so if the patient has heart failure secondary to iron overload, it's really the most effective drug for improving cardiac function, which is actually what kills patients with iron overload. And this is available now in the United States as well.